Welcome to today's webinar, Increasing HPV Vaccine Uptake, Part 2 of ARHP's three-part webinar series on HPV. I'm Jessica Monmany, an Education Program Manager at ARHP, and it's my pleasure to serve as moderator today. Before we get started on our content, I have a few announcements to make. To receive continuing education credit for this activity, you must take the pre- and post-test. If you have not yet taken the pre-test and you are viewing this webinar live, you will find the pre-test link in your reminder email. The post-test link will be sent to you after the webinar. If you are viewing this webinar on demand, both the pre- and post-test links can be found below this video. In the webinar dashboard, you should see a chat box that you can use to enter questions throughout the webinar. Our faculty will answer as many questions as possible toward the end of the webinar. In 4 weeks, you will receive an email from ARHP's Education Department with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you've incorporated what you learned into your work. Completing the pre- and post-test, as well as this follow-up evaluation, helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. ARHP would like to acknowledge that today's webinar was made possible through an independent educational grant from Merck. On this slide, you'll see the Planning Committee disclosures. As you can see, Dr. Aletha Akers is a recipient of an investigator-initiated grant from Bayer Healthcare, and Dr. John Davis is a consultant for Motive Medical Intelligence. All other planners have nothing to disclose. Here are the learning objectives for today's webinar. By the end of our hour together, you will hopefully be able to do the following related to HPV. Discuss the burden of infections on the variety of populations seen here with an intersectional lens, address barriers to widespread implementation of the vaccine, explain preventive care benefits of vaccination, discuss the relationship between HPV and cancer, and cite recommended ages, doses, and intervals of vaccination, with an emphasis on numbers 2, 3, and 5, as you can see here. At this time, I would like to introduce today's presenters, Beth Kruse and Craig Roberts. Beth Kruse is a nationally recognized author, speaker, and expert advisor in the field of sexual and reproductive health and family planning, and brings 25 years of experience in providing direct services for low-income and underserved clients from diverse ethnic, racial, and cultural backgrounds. As the lead clinician for the Family Planning Program of Public Health Seattle, King County, Beth is part of a team that provides patient-centered specialty care in a full range of sexual and reproductive health care. Craig Roberts is an epidemiologist and physician assistant with more than 30 years of clinical and research experience in public health and infectious disease. He holds an appointment as an emeritus clinical assistant professor at the University of Wisconsin-Madison, where he worked as a manager and clinician in the Sexual Health Clinic at University Health Services. He is a past chair of the Sexual Health Coalition of the American College Health Association. An expert in sexually transmitted infections, he consults and lectures frequently on topics relating to college population health and infectious diseases of young adults. Without further ado, I'll turn the webinar over to Beth.
Hi, everyone, and thanks so much for joining us today. Really appreciate ARHP and its wonderful efforts and successes in clinician education and being able to bring us all together for a variety of really interesting topics. HPV is fascinating and a fast-changing field of investigation. And today's topic is part of a series. I hope many of you have been able to take part in some of the other webinars, but today's really goes deeply into the vaccination part of it. I am going to just start out our day today by doing an HPV, giving an HPV overview for those of you who haven't been able to make it to any of the other webinars, and just to set the stage. So, let me see if I can move this slide. There we go. The epidemiology of HPV, it is the most common sexually transmitted infection in the United States, and nearly all sexually active people will get HPV at some time. We can see the numbers here. Most new HPV infections occur in individuals who are between the ages of 15 and 24. Among females, the prevalence is about 25 to 27% in the teens, but reaches 45% by the 20 to 24-year-old age group. And the prevalence of any genital HPV is about 42%. Oh, among adults aged 18 to 59 years of age. And you can see here there's some further numbers from different CDC studies and prevalence rates. 80% of sexually active women will have been infected by HPV by the age of 50. We're going to look next at the association with HPV and different cancers. This research was published just last year, showing that an average of about 39,000 HPV-associated cancers were diagnosed annually, and of those, about 31,000 are directly attributable to HPV. The ratio for females to males are shown here. Of these cancers that are attributable to HPV, we have about 93% associated with the HPV types which would have been preventable with the 9-valent HPV vaccine, and fully 80% attributable to types 16 and 18 only, and those are types that have been included in all of the past vaccines, 2, 4, and 9. So in other words, an additional 13% of cancers will be prevented in the future by the use of the 9-valent vaccine. The estimated proportion of cancers attributed to HPV in the U.S., looking a little deeper, we can see how it breaks down here. The Center for Disease Control and Prevention partnered with 7 U.S. population-based cancer registries to obtain archival tissue for cancers diagnosed between 93 and 05, which is fascinating. The HPV testing was performed on about 2,700 patients that were pretty representative of participating cancer registry cases. And demographic and clinical data were evaluated by both anatomic site and HPV status. As you can see by this table, HPV detection was highest for cervical, anal, and vaginal cancers. But among the head and neck cancers, HPV detection was the highest for oropharyngeal cancer. And you can see that although types 16 and 18 are involved in at least 50% of the cancers at all sites, they contribute a clear majority of cervical, anal, and oropharyngeal cancers. And just as a side note, it's interesting to look at the gender differential where it diverges, especially the non-valent sensitive distinction between anal and oropharyngeal cancers. Oral HPV infection is an area that really is just now beginning, we're beginning to know more about this, unfortunately somewhat related to the tripling of cancer incidence in the past 3 decades, from about 1 per 100,000 to 2.6 per 100,000. This is from a new study this year by Bui et al., looking at data from an NHANES study between 2009 and 12 that investigated the prevalence of and risk factors for oral HPV infection with multiple genotypes in the U.S. And it shows the difference between the binary gender, male and female, prevalence here. And we know that risk factors for oral HPV infection include cigarette smoking, ever performing oral sex, which is interesting, and then a higher number of lifetime oral sex partners, and even a higher number of lifetime any sex partners. So before we go any further, I'm just going to propose this. I'm going to plop up this little case study. There's not a lot to it, but I just want you all to think about Eric as we go through the rest of the webinar, keeping him in mind, considering our objectives today for integrating intersectionality, barriers to care, including barriers to vaccination, the burden of disease, the relationship of HPV infection to cancer and cancer of different sites, and then the vaccine recommendations and implementation and some of the challenges there. So just be thinking about what might be the next steps in the management of this patient. And while he's concerned about his risk for syphilis, what other things are you concerned about with respect to his health, and what information do you need to better understand his risks for STI and for cancer? Oops, I missed a slide. Hang on. Here we go. Intersectionality. It's an approach that addresses the way gender and other social identities affect life and health, and the way that those variables interact with each other for every individual. So it's based on themes of social justice and aims to address the problems with inclusion and exclusion of marginalized groups. As an example, looking at HPV through the lens of intersectionality, we can see not only how gender or biological sex impacts HPV and its associated cancer incidence rates and vaccine policies, but also how race and ethnicity, gender identity, gender expression, sexual orientation, sexual and other behaviors, and socioeconomic status combine to influence HPV risk awareness, vaccination, screening, detection, and treatment. You can see also how helpful an intersectionality approach will also be in investigating other areas like pregnancy intention, ambivalence or avoidance, substance use and addiction, violence, and other important public health issues. Looking a little bit closer at racial and ethnic disparities in HPV and vaccinations. We have Black and Latino men and women who have greater proportions of or greater rates of HPV-related cancers and a more advanced disease at the time of diagnosis, and that there continue to be racial and ethnic disparities in the uptake of the HPV vaccine. For instance, while Black and Latina adolescent females have similar or even higher rates of initiating HPV vaccine than their white counterparts, studies show that Black females are less likely to complete the series compared with white women. There is also a study, the Cognitive and Emotional Responses to HPV in Men, or the CER study, testing men for genital HPV, exploring racial and ethnic differences in factors associated with HPV vaccine intentions among males. And this showed that non-Latino Black respondents, despite being educated about HPV on more than one occasion, were still less knowledgeable about that infection than were men in other groups. And that although non-Latino Black men were least likely to identify barriers to vaccination, such as cost and side effects, they were nevertheless the group that seemed least likely to be vaccinated. I also want to make a caveat just in general. In the slides that follow, we're using primarily gender binaries, as these are the distinctions that have been used in the research which have provided us with the data that we have. So it's what we have to work with. Now we have HPV in females for our purposes, born with female genitalia, self-identifying as female in the studies that we have to look at. And so we know that where genital warts can appear, and they can also be in the mouth or throat. We didn't used to, I've been doing this for a long time, and we didn't used to think so. We used to think that that mouth and throat HPV was very, very rare, and we're realizing now that not so much. And we talked a little bit about the age relevance. For all genders, HPV is easily spread by anal, vaginal, and oral sex, by fluid sharing during sexual activities, and genital skin-to-skin contact. We have prevalence in the U.S. about 27% among U.S. females aged 14 to 59 years, about a similar number, about 24.5% in the age group of 14 to 19, but close to 45% among women aged 20 to 24 years. And risk factors, as you can see here, young age at sexual debut, and having many sex partners or partners with many sex partners. HPV prevalence here. This is a really, just a lovely slide to show how effective the vaccine has been. And the 4 types of HPV that decreased since the very first vaccine, which was the quadrivalent, 71% among younger females and 61% among the 20 to 24 age group, and really strong decline from 18.5% in the pre-vaccine era to 7.1% in the recent vaccine era, 65% decrease in prevalence among the 18 to 24-year-olds, and also a 40% decrease among unvaccinated females, which is really awesome because of the suggestion of herd protection for those who have not been vaccinated. Now, HPV in sexual minority women, very interesting body of work. It's limited, and one thing to remember here is sexual minority women is just the term that was chosen for this one example slide. In the research, we might see the term lesbian, WSW, or women who have sex with women. We might see bisexual. We might see WSWM, women who have sex with women and men, and heterosexual. Any of those definitions may or may not be more specifically defined. And Haynes also uses non-heterosexual. So it's sort of all across the board. Oops. In terms of actual behaviors. But just as a brief slide, we know that sexual minority women self-identified as sexual minority women often are screened at lower rates than self-identified heterosexual women. That it does appear in women who have reported never having a male sexual partner, including precancerous cervical lesions. And of course, routine cervical cancer screening should be offered to all persons with a cervix, regardless of their gender identity or sexual orientation. In males, what's really interesting here is that in distinction from HPV in females, older men are as likely as younger men to become HPV infected. And that is a biological gender difference. For any gender, HPV symptoms may develop months or years after infection. Persistent HPV can cause either warts or cancer, and in men, the anatomic locations are as follows. The prevalence of the type-specific HPV by anatomic site or specimen. This is really interesting. This is an older study. It was done published in 2007, but it showed a cross-sectional study of HPV in about 463 men over the course of 3 years. These men were selected between 18 and 40 years old. They had had sexual intercourse with a woman at least once within the past year, had no previous diagnosis of warts or penile or anal cancer, no current signs or symptoms or diagnosis of STD. And the external genital samples, the glans, corona, shaft, and scrotum, were significantly more likely than the anal samples to contain oncogenic HPV, 25% versus 5%. And the HPV positive samples were also more likely to be infected with multiple HPV types if they were on the shaft and glans or corona than on other sites. And of course, there is a wide difference in sampling technique, which may partially explain incidence and prevalence. HPV and MSM, men who have sex with men, this too is a whole field of study in itself, but very briefly, we have a 30-fold increased risk for anal HPV infection in men who have sex with men who are also HIV positive, and that men with immunosuppressive conditions, including HIV, and men who receive anal sex are more likely to develop HPV-related cancers. We do have some new techniques. They haven't been FDA approved yet for self-collecting tests for anal cytology, but early studies are showing that those experimental tests are acceptable, well accepted by MSM, and certainly HPV vaccination is indicated in men who have sex with men at least through age 26 years if they haven't been vaccinated when younger. And that it does reduce vaccination even after the year after initiation of anal sex reduces intraepithelial neoplasia. And with that, I will pass along the mic to my friend and colleague, Craig, epidemiologist par excellence, who will take you through the focus of our webinar, vaccines.
Great. Well, thank you very much, Beth. That's a very nice thing for you to say. And good afternoon, everyone. I'm happy to be here. And we're going to spend the rest of the webinar focusing in on vaccine issues specifically and vaccine recommendations. So what I'd like to do first is just review the current ACIP recommendations. These were revised about a year ago, and pretty much remains very similar to how the recommendations have been in place for the last 5 years or so, but they did make some wording choices, which I'll go over with you. So in the top box are the basic recommendations for vaccination, which is we should be routinely vaccinating all adolescents at age 11 or 12 years. That's the age for the routine receipt of the immunization. It may be given as young as age 9. That really is at the choice of the provider or the parent. Secondly, the vaccine is recommended for females age 13 to 26 and for males age 13 to 21 if they did not receive routine vaccination at age 11 or 12. So that is the catch-up recommendation. And third, males who are aged 22 through 26 years may be vaccinated. So it's an elective recommendation for males aged 22 through 26 with the exceptions in the lower box. But for men who are 13 to 21, it is basically a should recommendation rather than a may recommendation. That's really the difference between those two things. In the lower box then are 4 special populations that have slightly different recommendations. First of all, for any child with a past history of sexual abuse, routine vaccination should begin at age 9 rather than age 11 or 12. Secondly, for men who have sex with men, the routine vaccination is given the same as for all males through age 21, and then additionally, vaccination is recommended through age 26 as a should recommendation. So that sort of trumps the elective recommendation above. Third group is for transgender persons, and this is a new recommendation that was added last year. Routine vaccination is recommended as for all adolescents above. In addition, should continue through age 26 for those who are not adequately vaccinated previously, so similar to MSM. And then the fourth group is for anyone with a primary or secondary immunocompromising condition. This includes HIV. Vaccination with 3 doses of HPV vaccine should be given to all males and females aged 9 through 26 years. So I'll tell you that this recommendation is a little bit confusing for some people just because of the way they split it out for men, primarily for heterosexual men who are aged 23 through 26 where it becomes elective. There is some discussion in ACIP about harmonizing this recommendation, which I think we'd all look forward to. And if they were to do that, the recommendation will basically be that everyone from the age of 9 through 26 should be vaccinated with routine vaccination at age 11 or 12. The other major change that happened last year has to do with the dosing interval. So this should be something you're mostly familiar with at this point, I hope. But the major change is that people who are immunized under the age of 15 need only 2 doses to be considered fully immunized and complete their series with HPV vaccine. And this is a major change. If the vaccine is initiated at age 15 or later, 3 doses are needed on the standard schedule that we've been using for about 10 years since the vaccine first came on the market. And the basis for this is that the data show, and is worldwide, multiple studies now, that giving 2 doses 6 months apart produces the same immunogenicity and efficacy as 3 doses given on the older schedule, provided that those doses are given under the age of 15. We know that the vaccine is much more immunogenic when it's given at a younger age, and that's the rationale for giving a routine immunization at age 11 or 12 rather than later in life. So basically, if you wait to give the vaccine until you're over the age of 15, you're going to need 3 doses. It simply isn't going to work as well as it would if you got the vaccine at age 11 or 12. This is an algorithm that's available on the CDC's website. And it basically helps you make those kind of distinctions. This algorithm, though, only really applies to people in the routine age of 11 or 12. So anyone who is older than that falls out of the algorithm immediately and follows the recommendations given in the CDC, full CDC guidelines, and we're going to go over those a little bit. But basically, you can use this to help you decide, at least for people who are at that routine age of 11 or 12, where they fall in the table and what should happen next, whether they need 3 doses or 2 doses. So to explain this a little bit, especially right now, where we're sort of in this transition phase where you're going to encounter a lot of patients and perhaps adolescents who were initiated their vaccine on an older schedule, but are now coming in to see you, what do you do? So we know that anybody who's under the age of 15, if they've received 1 dose of HPV vaccine and it was more than 5 months ago, they only need a 2nd dose to complete the series. And that really applies at any point. So if your records show that someone got their 1st dose of HPV vaccine at age 12 and they come back to see you at age 16 for their 2nd dose, they only need that 2nd dose to complete the series. They do not need a 3rd dose. What about somebody who is interested in the nonavalent vaccine that received only the bivalent or the quadrivalent vaccine in the past? The current recommendation is that those people do not need to be re-immunized. Booster doses are not necessary. There's nothing harmful about getting additional doses with the non-valent vaccine, but at least as a public health recommendation for the population, it's not thought to be cost beneficial to cover those 5 additional types. Although, as Beth mentioned, we do know that especially for women, those 5 types do account for about 13 to 15% of cervical cancers. Fortunately, most of the other cancers, vaginal cancers, vulvar cancers, anal cancers, and the oropharyngeal cancers in both women and men are primarily due to type 16 and some type 18. So they are primarily covered no matter which vaccine you got. We do know that if you receive the immunogenicity of the 2 products, the 9-valent vaccine is as good as it was for the 3-dose vaccine of the bivalent and the quadrivalent vaccine. And people who did receive both types, there was a small study that Merck did, showed that people developed antibodies to all 5 additional types more than 98% of the time. So there does not, the fact that they were separated does not seem to have any effect on the immunogenicity or the efficacy of future doses of the vaccine. So that's just an important thing to know, that if someone received the quadrivalent vaccine a few years ago and now they're coming back in and they need a 2nd or a 3rd dose, you can give them the 9-valent vaccine. It's not going to be any different in terms of efficacy or their immunogenicity. In terms of vaccine timing, for the reasons I mentioned earlier, vaccine is most effective when it's administered before any HPV exposure. So in general, we want people to be fully immunized and complete the series before they ever become sexually active for the first time. We know that in the United States, the mean age of first sexual contact tends to be around age 16 or 17, although there is a wide distribution of age, of course. And you can't really predict when someone's going to become sexually active. So that is the primary reason why we want to give the vaccine in early adolescence, because that is a time before most people are going to be sexually active. But it's also the time when their vaccine is going to be the most effective and they're going to develop the best immune response. Even if we knew they weren't going to become sexually active until 21 or 25 or later in life, you'd still want to give that vaccine at age 12 solely for that reason alone. It's a much better immune response at age 12 than it is at 15, 18, or 21. Here are some potential barriers to vaccinating adolescents that are raised by both parents and by healthcare professionals. I would say actually both parents and healthcare professionals, especially in the past, had relatively little knowledge about HPV, about how common it was. This is essentially a universal and ubiquitous infection. And as Beth mentioned, the epidemiology shows, particularly in older adolescents and young adults and older adults, it's a very, very common infection. And because of the way the vaccine was introduced in the United States, first with women and girls and then later with men and boys, there was a perception that boys in particular did not need the vaccine because they were an add-on recommendation. But these are some of the reasons you might encounter, particularly from other healthcare professionals or from parents. And all of these things can be addressed easily with a discussion with the family or the patient. Adolescent patients in particular, we know that the single most common reason why they haven't gotten the vaccine is the lack of a solid recommendation from a healthcare provider. If you were to do one thing, either yourself or as a discussion with colleagues, is to make a straightforward, solid recommendation that your child should be immunized for HPV. That statement alone will do a lot more good, really, than any of the other things we would even talk about today. Sometimes there are issues of lack of parental approval or consent, particularly if a minor who's 16 or 17 may want to be immunized, and in many states they would still need parent consent to do that, and the parent may be opposed to the vaccine rather than the adolescent. Many people are still not aware that the vaccine can and should be given to males. That recommendation was not made until first approved for males in 2009, and ACIP did not make a routine recommendation for males until 2011. So it's been 6 years now, but people still don't realize that males as well as females should be receiving the vaccine. Here are some tips for counseling adolescent patients about the HPV vaccine specifically. When dealing with adolescents about any issue, but especially this one, or any sexual health or reproductive health issue, make sure that you've established a private, respectful, and non-judgmental attitude and environment. Privacy is very important to adolescents, as it is to everyone. You may need to explain in your state that minors cannot receive the HPV vaccine without their parental or guardian consent. You should acknowledge the patient's gender identity and avoid any assumptions about his or her sexual orientation and behaviors. As we've discussed, the vaccine is generally indicated for everyone, regardless of their sexual orientation, their sexual or gender identity. Offer factual information about the vaccine and its purpose, and certainly allow time to encourage questions from your patients. Here are some potential responses to questions that parents may raise. And I won't necessarily read through all these, but we do want to provide them for you so you can have some ready-made answers. Why does my child need the HPV vaccine? Emphasize that this is a cancer-preventing vaccine. And as Beth mentioned, the data on cancer, especially for oropharyngeal cancer, is very alarming. Fastest growing cancer, HPV-related cancer. While cervical cancer rates are declining, oral and anal cancer rates are increasing in the United States. So all of these things sort of apply to that. How do we know the vaccine works? Again, the adult and the female prevalence studies, the NHANES studies now show remarkable success in the vaccinated cohorts in young women, adolescents, and young women through the age of 25, remarkable declines in the prevalence of HPV infection in those populations. And we're also seeing declines in the incidence of genital wart disease in younger populations as well. Probably this first question here at the top is one of the more common ones you may get. Why does my child need vaccine at such a young age? And the answer here is sort of one thing you can do, but I actually will also really, again, mention how much better the vaccine works when you give it before the age of 15. In addition, your child will only need 2 shots if you give it before 15 and 3 rather than 3, so there's that issue, and it's going to save someone, whoever's paying for those vaccines, is going to save them a lot of money, about 1/3 of the cost, of course, to be saved by healthcare plans, the government, or the insurers. And also the issue of why do boys need the vaccine? Well, this is a sexually transmitted infection. It is transmitted easily between people of any gender, any sexual orientation, any gender identity. And men, in fact, do get cancers at genital sites as well as throat cancers. Interestingly, the incidence of oropharyngeal cancer in men is 3 to 4 times higher than it is in women. So there's a huge biological sex difference in the incidence of oral cancers due to HPV. Here are some other things you can mention to help dispel parental fears by confirming some basic facts that we know about the HPV vaccine. It's incredibly effective, one of the most effective vaccines that we have available in medical care today. We know it prevents cancers, we know it prevents dysplasias. The vaccine is incredibly safe. there are basically very few serious side effects or adverse reactions associated with this vaccine. The primary side effect is pain at the injection site. Yes, it is typically worse than most other vaccines that kids experience, but there's great data showing that there are really no long-term adverse effects. The HPV vaccine does not interfere with fertility. It does not contain any harmful ingredients. It does not contain any DNA. It does not contain any live virus. Another common myth is the vaccine can encourage youth to become sexually active. There are multiple studies now that show that's not the case. And the vaccine is approved and recommended for both males and females. And we now know that the vaccine offers at least probably 12 to 15 years duration of protection, probably will be longer as we get farther out from the original clinical trials, and that cohort is being followed up to assess their long-term protection from the virus. We're not really doing a very good job, though, of getting vaccine into the arms of adolescents. This is data from the National Immunization Survey, just looking at the 2015 data versus the 2016 data. We do get better, a little bit better every year. It's really flattened off, though. But overall, in 2016, this is a survey of teenagers, 13 to 17 years of age. About 50% of girls have received either 2 or 3 doses and are considered complete, but only a little more than a third of the guys have gotten there. And again, we're now 6 years out from the ACIP recommendation to immunize boys. So this is climbing very, very slowly. And compared to other immunizations that are given at that same age of 11 or 12, such as the quadrivalent meningococcal vaccine or Tdap vaccine, those coverage rates are up usually in the mid to upper 80s. So HPV is really very far behind. We've surveyed parents, and this is from a few years ago, but published last year, this online survey of parents of males aged 11 to 17, 50% said they were unlikely to vaccinate. And most of that group felt that they would do so if a healthcare provider had actually talked about it and made that solid recommendation. And really, this is striking to me. And again, these are adolescents, so they're mostly seeing family practice providers and pediatric providers. 50% had never discussed HPV vaccine with their son's healthcare provider. Remarkable. So you all can make that difference. Something to be aware of is really to know your state laws where you are. In most states, you cannot administer vaccines to a minor without parental consent. There are some exceptions. They're listed here: California, New York, Washington. And each of those has slightly different ways that you can get around that. In some cases, the minor has to be considered emancipated. And there is some legislation pending in Minnesota as well. What about people over the age of 18? So this is probably the largest group that is missing on vaccine because we were doing such a poor job in this country of immunizing adolescents early on in the first 10 years of the vaccine. We now have this large cohort of 18 to 26-year-olds who are not immunized. And they're about to move into older adulthood or middle-aged adulthood past the age 27 and above, where we will lose the opportunity to immunize them. So if you see patients in this age group, and I know many of you do if you're working in family planning clinics or public health departments where you may not even see adolescents, you definitely are seeing young adults, do not miss the opportunity to immunize young adults who've largely sort of escaped from that pediatric catchment and are now you're the last chance they have to get immunized before they go out in the world and meet up with the adult population, where the prevalence of HPV, remember, is about 45% between the ages of 18 and 59. Unfortunately for adults aged 18 to 26, there are some additional barriers, as they're no longer adolescents for the most part. Once they're 19 and up, they're no longer part of the Vaccine for Children's plan. They may not have insurance that would cover them. If they have health insurance, at this time still HPV is considered a clinical preventive service that is covered by ACA, but many still do not have insurance, or they may not have any healthcare access, or they don't see healthcare providers regularly. So yeah, even if they're coming in for an ankle sprain or some routine visit, certainly consider suggesting and offering HPV at that visit if you can. Don't wait for a reproductive health visit. HIV individuals have a much higher risk of developing dysplasias and cancers from HPV infection, about a 30-fold increase in risk overall compared to people who are HIV negative. For that reason, again, ACIP recommends that people who are immunocompromised need HPV vaccine no matter what age they are, through age 26 for sure, and many would argue even over the age of 26, although that is an off-label recommendation. Little data about HPV vaccination in women who have sex with women, but there is some limited research that shows perhaps the receipt of HPV vaccine is somewhat lower, and that could be for a number of reasons, including less access to health care, or a perception that they are not at risk either by the patient or by their provider, that they have less to worry about. But we know that really isn't the case. And in some situations, actually, the incidence of cervical cancer and cervical dysplasia among women who have sex with women is actually higher than it is among their heterosexual counterparts. There's not a lot of data about the impact of HPV on oral HPV infection, because at the time the vaccine was developed in the original clinical trials, this wasn't really on anyone's radar. But there are a couple of new studies that have come out suggesting that, of course, it probably is as effective as it is for cancers at other sites. The prevalence of oral HPV infection is much lower than it is for genital HPV infection, but we know that right now oral cancers are the fastest growing HPV-related cancer in the United States. So the vaccine should be effective and is expected to protect people against oral HPV cancers as it does for genital cancers. So just to wrap up, we'll just review these resources, some additional resources for you to check out around vaccine issues and talking to parents and teens about HPV vaccine and answering those questions and so on. And I believe that will wrap it up for our slides, and we're going to open it up for questions and discussion. And I'm going to turn this back to Jessica.
Thank you, Beth and Craig, for that excellent presentation. Let's move on to some participant questions. So if you haven't already, please do feel free to use that question or chat box to enter your question. And our first question comes from Melissa, who asks about the myth of a seizure immediately after injection. Is there any truth to it, and how would you address it?
Sure, I can take that. So there is a low incidence of immediate vaccine reactions, which the primary one is actually syncope, which is why this was the first vaccine to have the recommendation that people should remain in the clinic or lay down for 15 minutes after they receive vaccine, and that's now been extended to other vaccines that are given to adolescents. It appears that that is not a phenomena that's associated with HPV specifically, but rather with just receiving an injection, because it's been shown to be true with other things as well. Sometimes when people have syncopal episodes, if you don't get them supine really quickly, they will have a brief seizure or seizure-like activity. There's nothing unusual about that. It's and that's probably where this myth comes from, but it is not. The vaccine is not inducing the seizure per se. Again, it's the injection and the lack of blood flow that results from a syncopal episode that produces the seizure, if that happens. But it's a very low incidence, and again, it's not associated with HPV vaccine per se, but it's really an issue with immunization. And so, as a general rule of immunizing adolescents, you should have them on an exam table when you do that, and be prepared to immediately have them lie back if they appear to be syncopal in any way.
Great, thank you so much. That was a fantastic and very comprehensive answer. Our next question comes from Elizabeth, who asks, why is it not recommended for people over the age of 26?
So that is probably one of the most common questions that we get, and the short answer is because the FDA only approved this vaccine through age 26, and the reason they did that is because the company only did clinical trials on people through the age of 26, and FDA makes their approvals based on the data. And at the time the vaccine was initially approved and recommended, there essentially was no data for this vaccine being given to people over the age of 26. Now there is. So post-marketing of the original vaccine, some additional studies have been done, and it really, FDA will not probably approve an extension or an increase of the age unless the company comes forward with that data and requests a change to their label. That may or may not happen. It's possible that ACIP may independently make a recommendation or suggestion that people over the age of 26 could get the vaccine on an elective basis. There are a couple of other issues to think about with that. One is that it's still, at this point, you can give the vaccine to people who are 27 and older. It would be an off-label use of the vaccine, and you would need, so that may need special documentation in your records. It may need a physician cosign or approval, for example, or a medical director oversight. It probably will not be covered by insurance. That's probably the biggest hassle. But if it's indicated, if you feel it's indicated for the patient and they want to get it, and there's certainly people who are going to be at risk for getting HPV infection over the age of 26, there's no doubt about that. And then the other issue, though, is just to recognize that the older you are when you first get HPV, the less effective it's going to be. So most of the data from these clinical trials for this vaccine in women over the age of 27 shows about 80% efficacy, and I'm just rounding a number off from recollection. It's around 80%, I recall, efficacy compared to 98% if you give it at age 12. So that's just to give you a rough idea of what it is.
Great, thank you so much. The follow-up question there was, is it related to poor immune response to the vaccine? And it sounds like the answer to that follow-up question is kind of. Would you like to?
Well, kind of. I mean, again, the reason it's not approved over 26 is because it was never, the company did not develop the vaccine for that population, and so did not request that. And now we have some data that shows it works, but it doesn't work as well as it does in early adolescence. And there's also the issue, of course, by the time people are 26, most people have had sexual contact, and most of those people, at least early on, would have had exposure to HPV and presumed prior infection with HPV. And so in a little bit, when we think about immunizing people over the age of 25 or 26, it's sort of a horses out of the barn kind of issue, but it really depends on their individual sexual history and sexual experience, and that's something why this is really an individualized decision, and there probably will not necessarily be a public health recommendation or an ACIP recommendation. If it is, it will probably be an elective recommendation.
I think the gender differential is really interesting, though, here too, which is something that probably wasn't, you know, just because it's taken a long time to sort of bring the male gender into the loop, and then with the more recent finding that men continue to be at risk of acquiring HPV in older age, as opposed to women who sort of, you know, peak and then level off. And for men, you know, there very well may be different information about the relative efficacy and worthwhileness of for men continuing to get it into older age. And certainly 80%, I mean, if we extrapolate from the female, 98% at 12, down to 80% at age 27. 80% is still pretty good.
Yeah, right.
compared to a
Compared
poke
to
in the
flu
eye.
shot? So I had my flu shot today, and I don't expect anywhere near 80% efficacy over the next 6 months. So,
yeah.
But that's a really good point, Beth. And the other thing I was going to add, and I briefly touched on this, which is there are people that really recommend, in terms of, this is expert opinion, not a federal agency, that anybody with HIV infection should be immunized against HPV regardless of age, both men and women, because we know that if you are HIV positive, the risk of developing cancer from a persistent high-risk HPV infection is incredibly high relative to people who are HIV negative, 30-fold increase in risk. So GLMA makes that recommendation, and many experts in the field of HIV feel very strongly that people should be immunized against HPV, even though we don't know if it's necessarily going to make a difference in the progression of cancers, for example. But if they were to become newly infected, it might make a difference, preventing new infection.
Great, thank you so much. That's an excellent and comprehensive answer to the follow-up question. Thank you. Our next question comes from Ruby, who asks about your earlier point regarding using primary care visits that might be about a broken ankle to use those as an opportunity to talk about the HPV vaccine. And specifically, do you have any transitional talking points for busy primary care providers who are really trying to make the most of a single visit?
It is a challenge, and I would like all adolescents to be screened for chlamydia every year, and even if the ankle sprain is the only visit they have that year, it'd be really nice to figure out a way to, if not do it at that visit because it's so easy, probably easier than giving HPV vaccine, at least bring it up and mention it. Again, making that solid recommendation. So I think that the thing for the primary care provider to do, or the urgent care provider in this case is often the situation, is to just do a quick look and see if that person has had a primary care visit in the last year, where they've had a routine visit, and perhaps look and see if that's done. And I know you can't do everything in an acute care visit, in a brief visit like that, but immunization record review is something that's often is a simple thing to do and make sure people are up to date, particularly if they're coming in for an injury and you might be asking about their tetanus status. Maybe just ask about their HPV vaccine status, and if they know, that, to advise them that they should get it if they haven't had it done. I would say in our college health center, for example, we really encourage flu shots, for example, and we make an effort to, even when people are coming in for their ankle sprain, to during that 2-month period in the fall, to get them a flu shot at that visit, or to send them to our flu shot clinic to get that shot. So there are ways to think about if in your facility, if that could be set up so that you can have some sort of walk-in, drop-in basis to get a HPV vaccine for an adolescent, because it's such a priority, much the way you might do flu shots, or do them together.
Excellent, thank you so much. Beth, anything to add to that?
No, that sounds. I think that it's always the challenge, right? How do you fit everything in that you possibly can when you know that you might not see somebody again for a while. But I love the idea of, especially for primary care, if you're thinking about if you're looking at your little health maintenance ticker. I'm not sure. Come to think of it, if HPV is part of our EHR health maintenance topics, but certainly the other vaccines are. So that would be another thing to look into and see if your EHR includes the HPV vaccine in its health maintenance flags.
Right, and certainly should. I think particularly for adolescents, making sure they're up to date on all of that.
Yeah, I think we have to in family. I'm working a family planning only clinic, and our staff has to go and look into the Washington State immunization record to look up and see what the status of HPV vaccinations are for our folks, and it's not. It doesn't pop up. So,
Yeah, and our clinic is similar to that. We have to sort of step out and make a manual lookup to see
yep,
someone's immunization record in the registry,
yep.
rather than having it flow into the record, the EHR automatically. But I think it's still a really valuable thing to do. And routine sports physicals are another really great opportunity to touch on a couple of these things.
Mhm. Mhm.
Excellent. Thank you both so much. That seems to be all the time we have for questions. Craig, would you like to review the key points for everyone?
Sure. So this is just our closing slide. We just want to go over these things, what we talked about today. Recognize that a large proportion of adolescents remain unimmunized. 4 out of 10 females and 6 out of 10 adolescent males are unvaccinated. And the most recent data actually is 5 out of 10 adolescents, I guess. The optimal time to get HPV vaccine is in adolescence and prior to their first HPV exposure and before the age of 15. Vaccination continues to have benefit up to at least 26 years of age for persons at risk. Routine HPV vaccination is recommended for all adolescents beginning at age 11 or 12 and is recommended for females 13 through 26, males 13 through 21 if they were not adequately vaccinated when they were younger. And again, the major change in the dosing recommendations for persons initiating vaccination before their 15th birthday, the recommended schedule is 2 doses of HPV vaccine 6 to 12 months apart with a minimum of 5 months between those 2 doses. For persons initiating vaccine on or after their 15th birthday, they need 3 doses on a 0, 1 to 2, and 6-month schedule. CDC and other research shows that straightforward responses and messages work with parents when discussing HPV. Just discuss the facts and make that recommendation for the vaccine.
Great. Thank you both so much again for that excellent presentation. Before all of our participants exit this webinar, please note the following. As I mentioned earlier, today's webinar was the second in a 3-part series. The first webinar is available for on-demand viewing on our website. The third webinar will take place on Tuesday, November 21st. You can access these and other resources on different topics at arhp.org. As a reminder, please be on the lookout for an email from ARHP's Education Department with a link to the post-test survey. Your CME or Nursing CE certificate will be generated at the end of that survey. Be sure to print the certificate before closing the internet browser. If you have questions, just email us at education@arhp.org. Thank you for taking the time to participate in this webinar, and we hope you will take part in other ARHP-sponsored educational activities in the near future.
Thanks very much, everyone.